Well, good morning, everyone. Good morning. Glad to see you all here in the room. And I want to give a very special welcome to those of you that are joining us online. Welcome to the HEAL Collaborative Amgen New Life Community Alliance Lung Cancer Awareness Conversations. This is a wonderful event and a great opportunity to share about a very important and very significant disease that affects so many lives. Not only in the African American community, but in all communities and all ethnicities. Particularly, though, there is a unique effect in African American and low-income communities. And we're here today to talk a little bit more about the impact and the effect of this disease and how we can mitigate it, prevent it, screen for it, as well as treat it. So welcome. Glad to have all of you here with us. Let's begin with a word of prayer. Father, thank you for this wonderful day. It's a beautiful day, rainy here in Atlanta area, but the rain does not stop the beauty of the day. We honor you for being God and for being the sustainer and source and giver of all of life. And Lord, we've come today to talk about life. Talk about life in the context of this lung cancer disease. We know that there is such a challenge and so many issues surrounding this disease and communities of color and low-income communities in particular. And so we ask that you would give us the ability to speak clearly and to communicate effectively ways that we can mitigate and screen and treat this disease, and that you would restore hope to so many people who are struggling and dealing with the impact and the results of a disease like this. So many families have been touched and so many families have been hurt as a result of cancer and many other diseases. And so we pray that in the midst of this conversation today, that you would give hope and help to those family members who are wrestling with this, and that you would give encouragement to all of us that cancer is not bigger than you. And we give you praise in Jesus' name. Amen. Well, we've had quite a busy couple of weeks, and this is our second conversation. And last week, we had the wonderful opportunity to accomplish several things in helping us understand both the causes as well as the source of lung cancer. We unpacked the causes of lung cancer. We discussed all of the risk factors involved, such as smoking and radon, radiation, and others. And we had a good conversation about how this disease starts in so many people's lives. We got a clear understanding of why the health disparities exist in lung cancer detection and lung cancer screening, especially in low-income and communities of color, the disparities in terms of mortality as well as instances of lung cancer as opposed to other communities and other ethnicities. We have a good understanding from our conversation last week why early detection is important, why it's critical in beating this disease, being able to screen and detect it early. We covered what we as patients should be asking of our medical providers and our primary care physicians, and taking responsibility for our own health. What we've learned in our last conversation together last week is that you and we are the first champions of our own health. You are, in some sense, your first doctor, because you need to be able to ask the right questions, to communicate the right concerns, to demand the right kind of care, and be wise enough to know when you need to switch care providers if that ever becomes necessary, that you become the champion and primary advocate for your health. We also brought this information to not only this venue and this streaming market, but to this community at large, and communities like this, we pray, would extend around the country, because this information is critical for African Americans and for people of color to understand and to know. So we talked about so much on last week. It leaves the question, what's left to talk about? And there's so much more that we need to discuss. So today, We are here to have a clear conversation about screening, about detection, about how we can go about treating this disease, and to get into some technical terms that I think are going to be interesting for you to learn and to find out. But first, I want to get a chance to introduce you to one of our sponsors, our primary sponsor, and that is HEAL Collaborative. And today we have the founding board member of HEAL Collaborative, who is Mr. Howard A. Mosby. He is here with us. He is a founding board member of HEAL Collaborative, and he is serving in this capacity for this wonderful organization. And I'd love for us to receive him as he comes to greet us and to welcome us this morning. Please receive Mr. Howard Mosby as he comes.
Good morning. Good morning. You know, there you go. Here we are. Good morning. First of all, let's give New Life Church a big hand for putting this on. Pastor Harris has been one of the most wonderful individuals to work with. His heart for the community. If you see what New Life is doing, it is just so awesome. Everyone that I've known that's been introduced to this ministry has come back with wow as the answer. And we're happy to be a partner with New Life Church to do this, and working with our sponsor, Amgen, to put this project on. This really is about, HEAL Collaborative is really about how do we bring trusted information around your health to communities of color. And we work primarily through the church because we know that the church is still the most trusted voice in the African American community. Amen. Okay, I'm just make sure we're all on the same page here. This is going to be a great program, ladies and gentlemen. You're going to hear from some experts about how we actually are looking at the future in treating lung cancer. You're going to hear from some wonderful patients and caregivers in their journey along this space. And then we have one of the most premier state of Georgia elected officials here where we're going to actually talk about policy. And everything that we do is baked in policy. If you really want to make an effect in your life, you really have to affect the policy arena because it has a huge effect in your life. So we're going to be running our program through these different stages so that we can give you all this information so that you can be better informed in how you take care of your health. So with that, we're going to move this program forward. You're going to hear next from Dr. Eric Flanneau, who is a wonderful pulmonologist. But before we get there, we're going to show you a short video on how radon affects our entire environment. So ladies and gentlemen, buckle up. Let's rock and roll.
My name is Jackie Nixon, and I'm 73 years old, and I am a cancer survivor. I always was one that was big on exercising, eating right, so my health was perfect. I never had the flu in my life. I got one cold, maybe a year. I couldn't ask for more. The indication that I noticed something wrong was when I was singing. And for example, if I sing a note and you have so many beats to hold that note, I would get like half of the way and I'd lose air. And later on, it became apparent that part of the reason was lung cancer. The first thought was, oh my God, I'm going to die. I did think about, things I might have done in the past that might have caused it, but bottom line is that I never smoked a day in my life. I had the surgery, and I was home for 7 months. Once I was able to go back out again, I went to a meeting, And there was a gentleman there was a home inspector. Did you ever hear of radon? I can't explain it to you, but for some reason, I immediately knew that was it. I took my own money and I got the highest level monitors, and I asked my neighbors, because you have to test at the lower levels. So we tested the building, and Rose's apartment came out to 18 picocuries. The government level, EPA level guideline is 4 picocuries. I said, well, I know what I can do. And I decided that I was going to start my own advocacy, just basically start telling people.
I think specifically in Jackie's case, I mean, she was diagnosed with lung cancer in 2015. And that was in a very rapidly changing era for radon and lung cancer. Had she been diagnosed in 2000, we would have never even thought of her case as radon related. And so the timing of the two, her diagnosis and the growth in knowledge, sort of coincided. And as time went by, in Jackie's case, as the years went by, she became like a healthcare hero. And she helped educate, people around her, the general public, but also me, because then I thought, wow, this is real.
Pay attention to your health, period. Do not ignore things. Radon affects your lungs. You may not have any symptoms, 0 symptoms. So test your house for radon and know your numbers.
Good morning. You guys can do better. Good morning. Thank you. It's a blessed day. Thank you. So, my name's Eric Flanall. I am interventional pulmonologist and pulmonary specialist at Grady Hospital. I work at Morehouse School of Medicine. And a few years ago, we put together our lung cancer detection and screening program at Grady, and we had that down here. And I've been asked to talk to you today a little bit about what happens after the diagnosis and the importance of biomarker testing. And when is it helpful, and exactly what is it? I think everybody hears a lot about lung cancer. They hear a lot about treatments and chemotherapy and radiation. And a lot of the words, they get a little bit hard to visualize, to understand what's going on and what we're thinking. So I want to break that down a little bit and move forward and give you as much information about this so you can be empowered to help those that may be affected by lung cancer, or if it's yourself, to improve how your treatment moves forward. So let's talk about a little bit about understanding lung cancer and exactly what it is. We hear cancer, and the word never really comes to allows us to visualize exactly what's going on. So lung cancer begins with a change in your genes. And what basically happens is you have a normal lung cell, or you have a normal cell, and for some reason there's a genetic change. And from that, it starts to go to what we call a cancer cell or a pre-malignant cell. And the change that happens is it just divides and multiplies. And it multiplies and doubles in size, doubles in shape, and it gets so large it starts to invade other organs and spread and deplete nutrients from other rest of your system. And that's all lung cancer is. It's one cell that got out of control and then started taking over other parts of the body. And these genetic changes are called mutations. And you're going to hear this a lot as we speak. Okay? And these mutations are crucial to understand because they're what causes the lung cancer cells, or the cells, to grow out of control and to spread. Okay. So when we talk about mutations, we talk about biomarkers. These mutations sort of drive the whole lung cancer process, the driver mutations. And it's specific changes in the DNA that help the lung cancer do a few things. One, grow. The other is to thrive. There's to generate its own blood supplies. Because you got to think, if you have something growing in the body, it should die off once it depletes its own food chain, its own blood supply. But it actually allows it to grow its own blood supply. And then also these mutations allow it to spread so that the rest of the body doesn't recognize that there's something abnormal going on. So in the picture you can see that the lung cancer sits here in the corner here. The nutrients are coming in through creating its own blood supply to get it central to it. And then that blood supply has to leave, and with it, more of those cells move out and they spread to other parts of the body. And that's the basic concept of it. There's different mutations and biomarkers that we have, and some of them are activating mutations, and these are the ones where the DNA causes a specific change and it goes into uncontrolled growth. And some of the most common ones, if you know somebody that's going through this or that you're going through it yourself, to think about or to ask about is there's one that's a KRAS, a EGFR, and a V600. And you don't have to have these memorized coming out, but if you hear these are some of the more common ones of the activating mutations which allow it to grow uncontrollably. Okay. There's gene fusion mutations, and what happens is in the DNA, and it looks a lot of big words, but what happens in the DNA is the part of the DNA of that abnormal cancer cell is mixing up with normal parts, and they're just some of the normal proteins that are produced by the body are produced abnormally. And these gene fusions can drive cancer to grow and spread, because now you have a little bit of a normal cell and the abnormal part of it mixed, and it makes it harder for the body to recognize and to attack and to spread that. And if you ever hear some of the words you hear about ALK or ROS or RET, these are some of the common things that these little abbreviations, just to kind of keep in mind if you know someone that's going through that. So when we think about how these play a role, how does it affect the African American population? There was a study that the National Cancer Institute looked at. It's called the Cancer Genome Atlas. And so it's just a category of all of these genetic changes taken from lung cancer tissue that they've analyzed and said, okay, what are the genes that are playing a role in the aggressiveness of this lung cancer? And they sequenced genes from over 1,100 cancer patients. Now here's something that really plays a role when we start talking about healthcare disparities and differences in survival rates between African Americans, between whites, between Hispanics. One of the problems that we had with this atlas that was put together, of the 1,100 patients, only 83 were enrolled in that. Okay. So we were underrepresented in this study. And a little bit later, you're going to hear about the importance of us being parts of some of these clinical trials so that the information that comes out for the management and treatment recommendations that the physicians will use in managing the disease process we're being underrepresented in this, and so we're left out of the treatment, and so the disparity continues on. But what they did find from those 83 African Americans that were there, and they did the genetic panels, is that African Americans are more susceptible to lung cancer. We know that they're more susceptible to tobacco smoke because studies have shown that you can smoke less than other races but have a higher risk of developing lung cancer. So it's also the same with lung cancer, that they're more susceptible to lung cancer. And they've actually identified two of these genetic mutations that are more prevalent and play a bigger role in African Americans than whites. And what's interesting to know is that they're currently on the market. There are drugs to target these mutations already. So what exactly is biomarker testing? You're going to hear this a lot, okay? So biomarker testing is you're basically either taking blood, urine, or the actual tissue from the lung cancer, and you're running the test looking for these genetic mutations. Sometimes it's proteins which are secreted in the blood from the cancer. Sometimes it's the genes of it. Sometimes it's little markers on the edge of the tissue that your immune system will attack or attach to help destroy it. But they're detectable in these samples, and they can be, it takes about 2 weeks if you either give a blood sample, urine sample, or the tissue sample, and they can be identified. And there's several hundreds of them that can be identified, and from taking from that information, the clinician is able to figure out which treatment is most likely to work best for your cancer. In the past, the classic treatment for lung cancer was chemotherapy and radiation. But we start to realize that that is a one-size-doesn't-fit-all type of treatment. The radiation can be very harmful. People's hair falls out. They get burns to their skin. It's very, very caustic. And the chemotherapy, we've seen, they lose their taste, they get neuropathy, their hair falls out again, and it's just an unpleasant situation. But with the newer therapies, there's opportunities for pills. There's opportunities for shots. There's opportunities to upregulate your immune system to make it fight better against the cancer. And people actually do better and they tolerate it better and gets a better opportunity for survival. Okay. So what about biomarker testing in African Americans? Well, there are disparities there. First of all, the disparities, and I think you heard about this at the last discussion, that African Americans, they're often diagnosed at later stages. There's several factors that play a role into that. But that is the reality. So at a later stage, the cancer is more advanced, it's spread, and the survival is usually less. Okay? They wait longer and may not even receive treatment. And we've seen that. A lot of studies have shown that there's a significant portion of patients that are never even offered some of the treatment which is available for lung cancer. Okay? And they have lower survival rates. And that comes from a combination of a lot of the above, plus the ability to have access to places that will make available some of these newer treatments and testing. And when you think about biomarker testing, there's a study that was done a few years ago that looked at those patients that were eligible to get biomarker testing for their lung cancer and the percentages that actually had. Now, the numbers weren't great for all ethnic backgrounds, but only 14% of African Americans even received or were offered biomarker testing versus 20% of white patients. So both numbers are low, but the African Americans are significantly lower. But what we do know, and what we've known from years and years of treating lung cancer, is that when you offer equal treatment for equal stages of lung cancer, then all of these disparities go away. The survivals start to equate, and there's not this disparity between survival rates and outcomes if you give equal treatment. So this puts an importance on us to be able to have the opportunity for African Americans to have biomarker testing, right, and then get the opportunity for treating, especially when they're at risk for having later stage disease. So who should have biomarker testing? Biomarker testing, any new diagnosis of lung cancer, right? Because these new therapies out there, and there's about 35 of them out now for lung cancer, have been shown to improve the survival even for late stage disease. So whether you have early stage disease or late stage disease, you should be asking about biomarker testing. And then the big thing is, a lot of times patients will go if they're getting chemotherapy and radiation and they think the cancer's cured and it's gone away, and then either a new one pops up or the old one continues to spread and gets worse. Well, that's telling you that that one-size-fits-all treatment wasn't working, and now it's time to see if there's specific markers to target to give better outcomes in treatment, sort of targeted therapy. So if you have recurrent disease or metastatic disease, that's the person that would also be a good candidate for biomarker testing. And especially for African Americans who have higher diagnosis rates and higher mortality rates, the biomarker testing should be a standard in the treatment options, determining the treatment options. So how does biomarker testing help? Well, it identifies those unique characteristics, whether it gives you an idea about different therapeutic targets, response to treatment, whether it should be used in screening, but you can also tell about the prognosis, right? The response will give you an idea of the prognosis and the aggressiveness of the treatment. And then the monitoring or progression of diseases and some of the side effects. Because biomarker testing allows physicians to treat cancers with specific targeted therapies that's individualized for that specific patient, okay? And it helps track the response to treatment. Is it working? Is it not working? Do we need to switch? And if you look at the biomarker panel that you'll get, which may be 100 things that are tested for, you say, okay, this one should have about a 90% efficacy rate. This one about 80%. If this one isn't working, we still have another option. We have another option. And what we've seen up the street at Grady is patients with stage 4 lung cancer living 7, 8, 9 years after their diagnosis because the biomarker testing has given targeted therapy, and if something, it mutated again and wasn't working again, we have different options to treat. And the more options we have to treat, the better the outcomes are. Okay. So just an idea of the benefits target. This graphic shows a lot of numbers and a lot of things, but these are the number of biomarker tests that are available and the percentages that we can see occur within each cancer. And that's what helps the physicians give targeted therapy. And again, as I mentioned before, there are less side effects than with standard chemotherapy. Okay. The other option is immunotherapy. Right? So give you an eye about immunotherapy and how that's working, because you'll hear this word a lot, and I just want to make sure people understand exactly what's going on. These are medications or antibodies that are going to help your body fight against the lung cancer. So it boosts your immune system. And it does that by basically the tumor blocks your immune system from recognizing that it shouldn't be there. Right? So it puts a mask on itself. Well, what the immunotherapy does is it takes that mask away. Right? So it allows your body to recognize that there's a tumor cell there, and then your body's able to fight off. So it boosts your immune system. And you can give that either individually, or you can give it with other therapies. So now you not only have your own body helping fight off the lung cancer, but you can give other therapies which will attack in different areas, whether it's stopping the blood supply, whether it's stopping the growth. And all of that combined is a better attack of the lung cancer and improves the survival. So a lot of data, a little bit scientific. I hope that brings it a little bit more to what's going on and how they think about it and target it. So then the questions to ask if you're being seen by a healthcare provider for somebody that you know has lung cancer or yourself, when you meet with the physician, you should ask them, has biomarker testing been ordered for me? Why or why not? Okay. Will I need another biopsy or blood test for biomarker testing? How does this occur? Will treatment be delayed if I go through this? Okay. And is biomarker testing covered by my health insurance? You're going to hear a little bit more about the success that they've had with getting some legislation through. But these questions, I'm not going to answer specific on how to approach those. I think the next speaker, Jamie Knox, she's the owner of WJMS Radio in Savannah, and she is a lung cancer advocate through survivorship. And she has a powerful story that she's going to tell you about her course in her violence. So please welcome her.
Thank you. I always love presenting after Dr. Flanell because I'm like a living, breathing testimony to everything he's speaking to you guys about. So like he said, good morning, everybody. My name is Jamie Knox, and I am a stage 4 lung cancer survivor, patient, advocate, all of the above, really. And my story is similar to a lot of people I've met in the lung cancer community. It could be similar to a lot of you guys sitting in the audience right now. So my lung cancer diagnosis came from what started as a wheeze and a cough when I was going to bed at night, and it became a little bit more prevalent. So I went to my doctor. I was asking him what was going on and why was it happening. He gave me a breathing test, and then it came back inconclusive for both asthma or allergies. So he gave me an inhaler and sent me on my way. He said, use this for 2 weeks and then come back and let me know, how you feel. So I came back in 2 weeks, and of course I had nothing to say that was good because, at this point it's cancer and the inhaler's not helping me for that. So I told him, this didn't work. It didn't do anything. So he wrote me a prescription for a cough suppressant, and he sent me on my way again. And at that point, I realized I wasn't really getting any help out of him. And so I actually stopped going to see him because I just didn't feel like he was really hearing me or really seeing me as a patient. So fast forward a few months, and I'm in the gym, and I had at that point picked up kickboxing because it was something that I just happened to fall into, and I started to really love it. And I was putting on a little bit of weight, was in a comfortable relationship, and turned 30. They say your metabolism slows down. So I was on the treadmill with my husband, and I got to about a quarter of a mile, and I realized that I just wasn't breathing. And it wasn't one of those things where, it's like keep running and you'll get your runner's high, you'll feel better. It was like, no, I'm not actually getting any oxygen, and I had to stop running. And I knew at that point that something was really wrong, and I finally listened to the advice of my husband and went and got a second opinion. And when I went and got my second opinion, that was about 2 months later because I was a new patient, so they pushed me out. So mind you, my cough and wheeze began in, we'll say, April of 2018. And I didn't get seen by my second opinion physician until December of 2018. So that was several months later. By the time I saw my second opinion doctor, the first thing he asked me was, had anybody sent me for an x-ray? I said, no, nobody sent me up for an x-ray. So he sent me to go get an x-ray. I went right upstairs, got it done, and then I came back down to his office. And I'll never forget when I walked in the office, it was like all the blood had drained from his face. And he was like, are you feeling okay? And I was like, I'm tired, but I'm always tired at this stage of the game. It's just par for the course. And he was like, well, your entire left lung is covered in fluid. And he's like, we need to admit you to the hospital right now. And I was like, oh, okay, hold on a second. I wasn't prepared to hear all of that. So he did send me for a CT a couple of days later, which, that was on a Friday. The next day, my husband, who's active Army, he was shipping out to Korea. And I was like, look, let me just get through this weekend. And whatever this is, I will take care of it, on Monday. So I'm like, at this point in the game, like I've already gone, however long it's been. So I'm like, I just need 2 more days to tie up some loose ends and make sure some things are good. And then I can go to this doctor and get checked out. So in the meantime, I got a CT scan and was waiting for those results to come in. And I remember on Sunday I went to work, and that was the first day that I can remember that I really didn't feel good. And I couldn't pinpoint why, I just didn't feel good. And I called the doctor and I said, what was the results of my CT scan? And he was like, we need you to get to the hospital ASAP. And so the next day I went, and I was treating in New York at the time, and I went to the hospital. They admitted me. I was there for 6 days, and they drained 2.5 liters of fluid out of my chest, which is what I had been carrying around the whole time and what was giving me all of the issues that I was having, from back pain to shortness of breath, the wheezing and the cough. All of that was stemming from the fluid that had developed in my lungs. And so that was all drained out, and thankfully, they did biomarker testing on me. I sit here and I tell you guys right now, I had no idea that biomarker testing was a thing. I didn't know it existed, but I am so blessed and grateful that my care team did, and they did it for me without me having to ask. Because if I had done chemo or radiation, like Dr. Flanagan had said, I would not be here today. That's a one size does not fit all type of solution, and it wouldn't have fit me. So because they did the biomarker testing on me, I was determined to have the ALK positive mutation, which is one of the more highly treatable and manageable branches, I guess, if you will, of lung cancer. So it honestly, biomarker testing literally gave me my life back. Within about a month, I'll say, all the back pain was gone. I had 2 initial tumors, one that was, near my lymph nodes. I had one that was down by my liver. All of the sort of extra little tumors that were around were gone and non-reactive. And the main tumor that's on my left lung was shrinking, exponentially. So it was working for me and it was doing well. And within a month or 2, I was feeling like myself again. I was feeling much better. Still having issues with fluid developing in the lungs, but that's just because the medication takes a while to kick in and start working. But like I said, once the fluid subsided and everything was good, I literally am back to normal. I can go to the gym every single day. I can walk my dog. I can do a lot of the things that, had you said this to me back in December of 2018, when I first got diagnosed, I would have been like, it's over. I'm not gonna be able to do any of this anymore. And so I sit here just grateful. I'm thankful for the opportunity to be here talking to you in the first place, but also to be a part of something like the HEAL Collaborative and Amgen and everybody that I've worked with so far, who not only have taken me under their wing, but have allowed me to tell my story. And they've allowed me to take part in making history, because I was there to help give patient testimony to get Healthcare Bill 85 passed, which is the bill that just passed in Georgia that made it a requirement for insurance to cover biomarker testing. And a lot of people ask me, Jamie, why do you care? Why is this so important to you? And it's because, like I said, I didn't know to ask for biomarker testing. It was just something that was done for me. And when I found out that there are other people in the world who either, one, don't even get told about it, or it's not offered to them, or they can't afford it, or insurance doesn't cover it, whatever it may be, I just feel like it's criminal, you know? And if I can pay forward or pay back the blessing that I've got in some kind of way, then for me, it all is worth it. You know, and so being a part of getting this bill passed really makes me feel like I'm paying forward my blessing, and I'm helping other people get that same kind of treatment. Because I mean, yes, I treated up in New York, and it was a science or a university hospital, which is probably why they did it for me without asking, or without having to tell me. But it shouldn't be that way. Everybody should just have access to it, and it should be done for you regardless of your circumstances and your situations. Even if you are in a rural community with lack of access, there shouldn't be a reason why that's not part of your treatment plan if that's the best possible plan for you. And so I'm just grateful to be here today. I left out a whole lot of my story, but you know, you can connect with me after the panel. I just wanted to give you guys a second to ask us questions because he's presented a ton of great information, and I know you guys may have other questions for me. I don't want to take up all the time. So I will pause here and see if there are any questions from the audience. I don't know if we have to pass our microphones around.
No, there's mics.
Okay, great.
Dr. Flannel and Jamie, do most care providers know about biomarker testing?
I will say from a patient standpoint, a lot of the doctors that I've met at some events and things didn't know about it. You know, it's not something that's like taught in medical school or something. It's just not common knowledge that's passed down. It's more like a each one teach one, it seems like to me, because it's not something that's widespread known. And that's something I feel like from a patient standpoint.
Yeah, I think a lot of primary cares may, again, have a general concept or knowledge of it. Once you start getting higher into the treatment planning with your pulmonologist, with your oncologist or radiation oncologist, they should be familiar with it. But the goal here is to improve disparities by improving health literacy. And health literacy is educating you to know to ask, encourage, to get the message out, so you know what to ask for.
Other questions?
Yes. My name is Catherine, and I have 3 questions. The first one I wanted to know, y'all named about 3 different causes for lung cancer, about radiation and about x-rays. You may have 3 doctors, and they each send you to get an x-ray. Is that too much radiation? Because I am a breast cancer survivor, and I know about radiation and the side effects. So is that too much radiation? Or how much radiation are you allowed to get per month?
So the radiation that comes from diagnostic tests in the hospital is a very low dose. In fact, screening for lung cancer, we use a CAT scan, which is a low-dose radiation CT scan. And it's been calculated to decrease the risk of developing the lung cancer. So I would not be over-concerned about the radiation from diagnostic testing causing lung cancer.
Okay, and my second one is, if you have a history of respiratory problems, like allergies and sinus and bronchitis, are you more susceptible to get lung cancer?
So the biggest factor for developing lung cancer with other diseases is usually COPD, chronic obstructive pulmonary disease, or emphysema, mostly because that's related to tobacco use and tobacco smoking. The others, asthma doesn't give an increased risk, but if you have emphysema, if you have COPD, and that's related to a history of smoking, then that does have a high association of developing lung cancer.
And because of COVID, we're having to wear these masks, and it is hard to breathe with these masks on. And I find myself always kind of pulling it down to get some air. Should I be worried about that?
I wouldn't be worried about that in terms of developing the lung cancer. So the masks are preventative just from the infection component of it. Some of the mask mandates have lifted, but it's just going to be individual to the area where you are as to whether or not you continue to use it. But I wouldn't worry about wearing the mask giving you a risk of developing lung cancer.
And also, all my doctors are at Morehouse. And I want to thank you for realizing that every patient is an individual. You can't treat patient A like you do B, because they may have diabetes and allergies and GI problems versus patient A who doesn't have anything but that one particular problem. And I want to thank you guys for realizing that. I mean, it's too late, but at least y'all realize it. Y'all doing something about it, okay?
Thank you.
Good morning. Jamie, can you talk to us about the importance of family and advocates when you're going through your journey with lung cancer?
Can you repeat that? I lost a little bit of
Can
it.
you talk about the importance of having advocates, family, and friends as you were going through your journey with lung cancer, the important roles they played?
Oh my goodness. So they're critical. They're so critical. I will say when I first got my diagnosis, I was angry at my mom because she kept telling everybody in the family. She's like, they need to know. And I'm like, no, they don't. You know, I was very much to myself and I didn't want to talk about it. I didn't want anybody to really, you know, be pitying me or looking at me in some sad way and whatnot. And, you know, I was actually speaking with somebody on my show about the situations that she had going on. She had a few diagnoses and things like that. And she was talking about people with platforms who don't use it to help and don't use it for, you know, what it needs to be used for. And I remember feeling like that was sort of like a tap on the shoulder from God, like, she's talking to you. Like, you need to be using your platform to be educating people about this and becoming an advocate for it. And so I really started to lean into a lot of organizations. You know, my family has always been there. My husband, my mom, my dad. I throw up the bat signal and they come running. You know what I mean? So that is critical to know that they're in my corner. But there's also something different about being surrounded by people in the lung cancer community who understand what you're going through. You know, if I say to somebody, I'm having a bad lung day, people are like, oh yeah, they don't really understand. But if I say that to somebody in the lung cancer community, they're like, yeah, I know, you know, because they understand what I'm going through. So I will say that being an advocate in this space and talking about it and really being vocal and not hiding or, you know, just addressing the stigma in general around lung cancer is important, because there are people that are suffering who don't want to talk about it still, who aren't comfortable about it yet. And I would say just lean into your network, lean into your organizations, lean into the people that love you and care about you, and let them help you. Let them be your resources. I will say without the people in my life who have, you know, leaned into me and have let me lean on them, I don't know if I'd be strong enough to be sitting on this stage telling you guys my story. You know, I'm sitting here because I was boosted up onto the shoulders of the people that support me. And without them, I think that it would be a lot more of a struggle for me, and I think that I wouldn't be in the same wonderful mental headspace that I am about my disease as I am right now. So I definitely want to thank the people in my life who have been that advocate for me and who have let me advocate for them as well, for just the roles that they've played in my journey.
Thank you. Dr. Fernald, real quick, with regards to biomarker testing, this is a wonderful avenue with regards to educating folks. It's not just lung cancer, right? Like, can biomarker testing also be accessible with regards to other cancers?
Yes, all lung cancer is going to produce some of the biomarkers that we discussed. And it's interesting because early in the course of treatments, we knew about this with breast cancer, but now, you know, colon cancer, prostate cancer, there's the outcomes, the survival benefits of targeted therapy are so strong that just about any cancer type has availability for biomarker testing so they can targeted therapy against that specific cancer. So it just doesn't have to be lung cancer. If you know somebody with another tissue type of cancer, ask about biomarker testing.
Good morning. My name is Lori Prescott Harris, and I clapped because I wear a hat that says 150 years.
Can you step to the maybe the
sorry,
microphone?
we're having trouble hearing you.
Thank you.
My name is Lori, and I wear a hat that says 150 years. I'm coming from Hampton University area and Richmond. I have 3 generations of teachers, and I'm not one, but still, you know, it bestows a lot on me to be proud of our African-American men. As for you, young lady, I'd like to know, what is stage 4?
It's probably a question for Dr. Flanell more than me, but I'll answer it from my patient standpoint.
No, I want a patient standpoint.
Sure. So stage 4 essentially means that the cancer that has developed in my body had metastasized, meaning it had spread to other locations. And because mine had not just like the main tumor on my left lung, but I also had a couple of outliers as well, and the fact that mine started developing fluid, that makes it stage 4 automatically. Because once it's developing fluid, you know, I hate to say it, but that's kind of like a no turning back point. It's not a good place to be. So that's kind of what puts me at the stage 4 position. But Dr. Flanon might be able to give some additional scientific answers.
Yeah, so stage 4 is just that it has spread from its primary site, which the lung, so now it's either spread to the other side or to other parts of the body, bone, liver, kidneys, adrenal glands. So it's just that where it's spread, and it's sort of the last stage from that standpoint.
But I'm good though.
I know. That's the
I'm
reason
covered.
why-
I'm blessed.
No, that's the reason why I said,
Yeah.
please explain, because you took it real well. You were like, oh, well, it's stage 4, and she just kept on going.
All right.
It's like, no.
Well,
girl.
I will say I'm a regular person. I've gone through my 5 stages of grief. I've had my why me, what did I do, this isn't fair, you know, not to stigmatize smokers, but I never smoked. I have no history of cancer in my family. Like, I had no reason to suspect that lung cancer would even be something in my life. So I've gone through my process. I've accepted where I am. I realize that I have this disease for a reason, and I think it's because of things like this, because I can tell my story and I can relate to people and I can make it genuine so people understand that this can happen to anybody sitting in this room. All you need for lung cancer is lungs. That's it. So all of the, you know, smoking causes lung cancer, all that, that's just a half truth. The real truth is that all you really need is lungs. That's the only causal factor to get lung cancer. So for me, I realized that, you know, yes, I have this stage 4 diagnosis. It's pretty terrible. I'm not happy about it, of course, but I've gone through my journey with it. You know, I realize that I'm blessed still, and I look at other people who have lung cancer in the community who have gone through the gauntlet of things, and I'm just grateful for the path that I'm on. I'm grateful for the journey that I have right now, and I just take every day as it comes. There are some days that are harder than others, but I'm very much in tune with what's happening with my body and how I feel, and I just listen to it. You know, I may not have listened to it in 2018 like I should have, but I'm paying attention now, and I do what I need to do to make sure that I stay in a good space, both mentally, emotionally, spiritually, and physically.
I have one more. What does it mean to be, I hope I say this right, genetically dispositioned for, did I say that right? To have a genetic disposition for certain, or possibly have that, well, I don't think I pronounced it right, or I said it right.
So when we say there's a genetic disposition for lung cancer, it means that there's something about the person's DNA, that may even be hereditary.
Because I had one for hypothyroidism,
Yeah,
and I had lymph nodes also behind mine that had to be removed, and they removed the whole thing. Yeah. And he said, I did not want you to have cancer, but I always want you now to, this is just me, I want you to always pay attention now to having a disposition for swelling. Swelling is very important, contrary to what people think.
Yeah, so there are dispositions of people that are increased risk or likelihood of developing cancers. And we're starting to find that out more and more. Kind of will move into the next discussion that we have coming up, because we're learning that we won't find out about a lot of these dispositions, a lot about understanding the nature, the risk factors for lung cancer until we're involved in clinical trials. And that's one thing that I think the African American community needs to look a little bit more into. But we have an expert coming up next that'll talk to us about that. Dr. Lawrence Sanders.
Yes. So thank you guys for your questions. I think, you know, Dr. Flanon and I will be available after the panel if you guys have more that you want to ask us. But it is our pleasure now to introduce Dr. Lawrence Sanders, who is internal medicine at the Grady Health System and the Chief Medical Officer for the HEAL Collaborative. So.
Good morning. My name is Lawrence Sanders. I think you heard I serve as an internist and work at Grady Hospital every day. And I really want to thank you for the opportunity to do this, but I really want to just take a minute to let the power of the information that you've heard so far sink in. because you've heard about how we have taken a disease that 15 years ago there was very little hope for and turned it into something that adds years of productive life. Now that's important because that is the result of the research that's been done in this area. So my job for the next few minutes is to talk to you about a type of research called clinical trials, to illustrate how clinical trials have improved care for lung cancer, and to talk about why we, as African American people, people of color, the sons and daughters of slaves, need to participate in clinical trials. So that's my task, and so I'm going to get started. I'm going to start by just illustrating the importance of research and what research is, and then I want to take it to clinical research. I want to start with research. I think you've seen research from improve the treatment of lung cancer, but I'm going to give you another example of research. All of us today carry in our pockets what we call a telephone. But if we go back 30 years, that telephone was on the wall. And some of us might even remember when you couldn't connect long distance without having somebody do it for you. And the fact that we now have these devices in our pockets are the results of people having ideas, testing those ideas, and then putting them into practice. And so that's what research is all about. Now, when you involve people in research, it gets called clinical research. And clinical research is a type of research that has helped us make great strides in medicine. So now let's talk about clinical trials. And the best way I know how to get started is let's talk about what a clinical trial is. Now, there are two types of clinical research. One is that I take a disease or I take a condition and I observe people with that condition over time to learn how that disease progresses, how it works, and learn how I might intervene. So that's one way. That's called an observational study. A clinical trial, on the other hand, is I take a new treatment, determine if it's safe, and then compare it to standard treatments to allow me to then choose which treatment is best. And I think you've heard clearly the advances that we've made with lung cancer. So now let's talk about clinical trials. Clinical trials come in 4 steps. They're called 4 phases. The first phase of the clinical trial, phase 1, really takes healthy people, gives them a new medication, but it's not limited to medication. It could be an intervention about prevention. It could be a behavioral change. But most often, it's new medications. And the first thing that we want to do is to make sure that medicine is safe and understand what the side effects are and understand how much of the medicine or the dose needs to be given. So that's phase 1, and it usually involves somewhere between, I'm going to say, 50 and 100 people, a relatively small group of people, usually healthy. Once we determine that the medicine is safe, then we want to make sure that it works. And so then we begin to test it on people with certain conditions, and in this case, people with lung cancer. And we call that phase 2. And again, it's to make sure that the medicine is safe. It's to make sure that now that it works and does what we expect it to do, or that it is effective. So that's phase 2. Now that we know it's safe, now that we know that it works, we want to test it on more people. And we want a larger group of people, a diverse group of people, such that we can see how that medicine now works in different people. And usually this phase of the trial is called phase 3, and it involves anywhere from 1,000 people to maybe 5,000 people. And that's why we as people of color need to participate to make sure that these medicines work for us as well. Now, phase 4 is after the medicine has been approved, We continue to watch people who are taking that medicines because new side effects may develop as more people take the medicine, and we want to be aware of those, and then we can make the necessary changes. So if you've heard what I've tried to say, about clinical trials, first and foremost, we want to make sure the medicine is safe, that understand what its side effects are, and make sure it works. And these are the 3 phases of clinical trials. So now that you know what a clinical trial is, I don't really have to tell you all the benefits of the clinical trials because you've seen them. You've heard them real life. I think Ms. Knox and Dr. Flanell gave you a good outline of how we as people have benefited from clinical trials. But I would tell you, if I go back to 1900 and you think about the advances that we've made in medicine, most of them come out of research and clinical trials. At the turn of the century, life expectancy was probably 50, 60 years, and even less for African Americans. But because of new medicines like penicillin that we use to treat infections, people have enjoyed much longer lives and had many years added to their life. And that is the benefit of clinical trials. Specific to lung cancer, you've heard how we have not only new treatments, but we've heard about new ways to detect, early detection. We've heard about new prevention strategies. And this will continue as long as the research continues, because what we've done is we have now moved the disease, lung cancer, from the time the diagnosis was made, where many people didn't expect to live very long, to where now we have added years of productive life for the patient and their family as a result of the outcomes of this research. Now, so why is it that I'm standing here to talk about participation in clinical trials? Because in my mind, we all want to go out now and figure out, how can I participate in a clinical trial and make it work? But let me give you the facts. African Americans and other minorities make up about 30% of the population in this country. If you look at clinical trials, they make up only about 15% of the people who participate in clinical trials. If I go specifically to African American people, we make up about 12% of the population, maybe a little bit more, but only 5% of us participate in clinical trials. Now, why is that? Why is that? Interestingly enough, if we go back, most of the participants in clinical trials were white and mostly white men. So why don't we participate? Well, first of all, I can think of my own patients and my own experience at Grady Hospital. I've had more than one patient say to me, "Doctor, you're not doing no research on me, are you?" Because most of us don't want to be part of research and experimentation. And despite many, many efforts to reverse that, we still don't have the level of participation. So now let's go back and let's try to unravel why we don't want to participate. There's no doubt that some of it has to do with a thing called slavery that lasted for 400 years and another 100 or so years of systematic oppression, and what I describe today as the delicate dance between the sons and daughters of slaves and the sons and daughters of slave owners as we try to figure out how to move forward in this complexity of trust and mistrust. And even more importantly, there are very few of us who don't know or haven't heard about what happened in Tuskegee in the beginning of the 19th century and went well into the end of the 20th century. So many of us haven't gotten over that. Now, let's talk first specifically about the Tuskegee syphilis experiment. That was an observational study where physicians from the Centers for Disease Control observed people when we didn't have treatment, but where things went wrong is that they continued to observe people and withhold the treatment even after the treatment was available. Now, it's hard to trust people on that line. Very hard. Let me take that story a little bit further. You know, you never know where you're going to end up in life, but after I finished residency, I spent 2.5 years of my life at the Centers for Disease Control in the very division that did that study. And at the time that it was coming to an end, and the people in that division realized that something had gone wrong. Something had gone very wrong. So what has happened subsequently? Centers for Disease Control and the federal government apologized for that event. But more importantly, it led to putting safeguards in place to protect people who are engaged in research projects. One of those safeguards is you got to know that the people who are doing the research have to tell you. And if you heard anything as I described clinical trials, it's about safety, safety, safety. So the safeguards that we put in place may not erase our experiences, but they at least make it possible for us to participate in clinical trials without thinking that things are going to go wrong. So let me just take this one step further. So you think about it and you say, nah, I still don't want to participate. And many of the advances that we made with white men participating in these trials have benefited all of us. And if you think about it even deeper, though, this is where I think it becomes important. I'm going to try to make the case for why we need to participate. You know, human genetics, and I think Dr. Flanell talked about the human genome and how many strides we've made or how great the progress has been over just the last 20 years. But the one thing we know is that when it comes to human beings, there's not much difference in my genome or your genome than our white brothers and sisters as well. That there's less variation by race in the genome than anything else. So what makes the difference? It's because medications and other interventions are different because of factors such as where people live, the neighborhoods people live in, where they grow up, where they work, how they get educated, and all of those factors may impact how a medicine or a treatment works. And so the only way we can make sure that the medicines benefit everybody is to have participation. And to make sure that the guidelines and the guardrails and the safety mechanisms are in place, and don't hesitate to ask questions. Now, I'm going to give you 2 more ideas about what we might need to do in the future as more of us agree to participate in clinical trials, and we recognize the importance of it, and also recognize that it benefits all of us. Now, if you look at the people who do the clinical trials, not many of them look like you and me. So we need to increase the number of researchers who are African American and who can connect to the patients that they take care of and that who are involved in this research and care about those patients. The second thing we may need to do is we may need to look at how we do these clinical trials. So often now you have to go to the clinical trial. That's not often easy. Transportation, time, all of those things. we may have to look at ways to bring the clinical trials to the neighborhoods and communities where people live and work, worship, and do all the other things that they do. So clearly, changing mistrust that is grounded in 400 years of experience, 400 and more years of experience, is hard. But I think working together, we can make sure that it is safe for all of us to participate in clinical trials, and that allows us to extend the benefits of the research to everybody in every neighborhood in DeKalb County, every neighborhood across this city, across this state, and across this nation. Because it's about all of us working together to create the conditions in our neighborhoods where we can be healthy and have the best opportunity for a healthy life. And for us, we have to make sure that everybody gets the benefit of the advances that we make in medicine, improving health, and improving the quality of life. Thank you very much, and I'll be glad to answer any questions that you might have. Go ahead.
For the trials that you're talking about, don't you need some type of incentive? Okay, for instance, I participated in the research for diabetes because I'm diabetic type 2. And I participated, and they had a car to come pick you up, and they gave you the free medicine. They gave you the everything that you needed, you know, to test your sugar with and everything. I mean, so the programs that you're talking about, shouldn't they have some incentive? I know that you said move into the area, but you know, we still have to get there. I mean, and we might not have bus fares. And I know they paid, I think it was $30 per visit when I went to the diabetes. So can y'all have some type of incentive? I mean, I'm sorry. But anyway, if you do that, that might bring people out. If they just came out just to get the money, they don't know that they'll still be helping. I mean, but you have to do something. And like you said, that Tuskegee incident, me being old school, that's still in the back of my mind, and I don't want to be nobody's guinea pig. I mean, you know, you got to show me something. Don't be just experimenting on me. And then now, if you look at TV, every medication, they start telling you about the side effects, and then you get to thinking, I think I much rather have the disease than to take the medicine. So you know what I'm saying? So you need to kind of help us out there. We appreciate what you're doing, you know.
Well, I don't know that I need to answer the question, because I think that based on your experience, you've laid out all the things that need to be done.
Okay.
That folks who want to do these clinical trials need to meet people where they are. And most clinical trials provide incentives. And there's another benefit of clinical trials that I really didn't talk about that I think is important. Sometimes clinical trials will give people access to medicines and treatments that they may not otherwise be able to afford or have access to, and that helps with improvement, okay? And that helps the individual as well as all of us benefit from their participation. But I think the things that you said, they came to pick you up, they provided incentive, they provided the medications, and they made it as easy for you to participate in that trial as possible. Did I understand?
Yes, and they also listened.
And they also listened.
They also listened.
They also listened, and that's the other important thing. So if you're going to participate in a clinical trial, those are the kinds of things you need to look for. But I think that last one is the most important, that they also listened, all right?
Okay.
And none of us want to be experimented on, but I think participating in clinical trials moves beyond people experimenting on us for their own benefit, but it allows us to participate in research that leads to advances. Does that make sense?
Yes. Thank you.
All right? Yes, ma'am.
I appreciate you because I was going there. I got up because of the part that you were saying. Sometimes you.
Say one more thing before she starts.
Is that okay?
That's fine.
Just one
All
more
right,
thing.
go ahead.
One thing about God, God knows who to give illnesses to. He needs somebody like me and like the other young lady that's not afraid to tell their story and that will speak up. He don't want to just give you something you don't tell nobody about it. He wants you to continue to pass that blessing on. I mean, the reason I say that because he's given me some of everything. So every time I have an opportunity to come to a forum like this, you better believe I'm going to have a question, I'm going to speak my truth, I'm going to say something to let somebody else know because they might have that same question, but they're afraid to ask. But then here I come. I ask that question for them. So I take my hat off to you, young lady. I really appreciate that. And believe it or not, you got angels around you. That's another gift that he gave you. So you're going to be all right. Okay?
Thank you very much. I couldn't ask for any better comment or any other summary of what I talked about. Go ahead.
Okay, I'm going to be a devil's advocate right now. I appreciate you so much about your diplomatic way of handling things as far as the financial part of things, because we do have a tendency to sometimes think that the reason why we don't have the situation underhand is because a certain class of people can afford it and a certain class of people cannot. Excuse me, but I go to grading. And so this to me is preventive care and also caring for everyone.
It's true.
And so it's not a white thing, it's not a black thing, it's I care thing. And I don't take care. I take care of you.
Thank you very much. I mean, I think that part of what I would add to that is that is the importance of the policy framework, because we need to make sure that every American, everybody that lives in every neighborhood in this country has access to affordable and high quality health care. And it shouldn't be limited, if you will, to a certain class of people. And that's why we work every day at Grady Hospital as part of the healthcare safety net to make that happen.
Hello, Dr. Sanders. If I enroll in a clinical trial, complete it, and how will I be informed about the clinical trial results?
How will you be informed about the clinical trial results? How do you enroll? Sometimes you can work with your primary care physician to help identify clinical trials when you are working with an oncologist or radiation oncologist or a pulmonologist, particularly for lung cancer, or a specialist. They should know about available clinical trials and help you get enrolled. And the clinical trial team should be committed to keeping you informed, both about your individual results, and that's where listening comes in, to make sure they're listening and paying attention. And you should also know the outcome of the clinical trial and how it moves other medications forward and how it adds to making it better for all of us.
All right, Dr. Sanders, I have a question as a patient, of course. If I was to participate in a clinical trial, when's the best time to do it? Because right now I'm in medically induced remission, if you will. I'm stable, no progression. So it's like, if it ain't broke, don't fix it. Should I jump into a clinical trial, or should I wait until maybe I've had progression to start a clinical trial to see if that's best?
Ooh, that's a difficult question.
I know, that's what
That's
I'm
a
asking.
difficult question. That's a difficult question. That's a very, very difficult question. When should you participate? Well, if you're starting treatment and clinical trials are available, I'd say yes. Let's go ahead and find a clinical trial. If there are not a lot of treatments available, that may also be a time to find a clinical trial. If you've got a recurrence, that may be a time to find a clinical trial. And now you're going to get to know a little bit about me as a physician and how I think about these things. Look, if what you're doing is working, it's not progressing, I don't mess with it. You know, that's how I am. And the most important thing, and you really helped me, man, and that is the most important thing when you're working with your physician or clinician is to make sure they're listening to you. Okay, go ahead.
Thank you, Dr. Sanders. As a mother of a 20-year-old son, what is it, how do we get more youth involved or acceptable to wanting to do clinical trials? Like, we understand the historic implications. A lot of the youth are not even aware of the Tuskegee experiment. Now, here we are in 2023. How do you get the youth wanting to be more, particularly people of color, black folks, students? How do I message that to my son and his friends?
Well, I don't exactly know how to do that. Some of what I tried to do today was create that message. But I also think that we have to really illustrate the benefits of clinical trials, that they are safe, shouldn't cause any harm, and that folks aren't doing research on you, but you are participating in research to create advances that will benefit us now, but more importantly, will benefit those who come after us. And so creating a sense of, I'm here and now, but if I can contribute to improving the quality of life for those who come after me, may very well be the message that we have to put together. But that message not only impacts clinical trials, it really does set the stage for how many of us should live our lives.
Hi, my name is Angela. I missed the first session, so some of the things that were covered I may have missed out on, like predisposition, hereditary, that type of thing. I have family history. I think I'm a healthy person. I've not been diagnosed with anything. I try to be mindful of my body, be my own advocate. I've learned over the years that you have to do that because doctors do not any longer really do that for you as much. You have to go to those lines of the companies that now you have to go online and pull up your own results from your test and things like that, whereas you could go to the doctor or they would notify you and tell you what the results of your test were. They don't do that anymore, okay? So, and as far as, I have, my father died of lung cancer. My sister has non-lymphoma, non-Hodgkin's lymphoma. So she's recovering from that. She had breast cancer prior to that. I don't have, too close. So I'm concerned, if family history is an issue. That really concerns me. Like I said, I think I'm healthy, so why would I want to do a clinical trial to be given medication for something that I don't necessarily have? And I do have a trust issue. I have a trust issue with pharmaceuticals and the companies that provide them. I think that a lot of medications they give you before they have fully been tested. My mother took metformin. Now there's a big issue about, and she hated it. It totally destroyed her quality of life. And I didn't understand. I just said, you got to take your medication, mama. And now I see from different things that I read that it was really changing her whole quality of life. It hurt her, as the lady said. It was, the disease was better than the medication that they gave her. So that's an issue. I know in college, they offered incentives for us to go and do experiments, kind of, or be tested for different things. And they actually paid the students to do that. I don't see why they're not, or maybe they are still doing that. That was a long time ago. So let me see. And also because I came because of my family history to the seminar, because I want to know, are there signs or symptoms that I should look to or consider if, I got a pain in my back. I have a pain in my back periodically. Is that lung related, or is it heart related? Yeah, I used to be a smoker. I'm no longer a smoker, but, I've heard things about that going away after you quit for 10 years, but, who knows? Let me see, what else do I have on here? Prevention. Like I said, the main question, for me to participate in a clinical trial as a hopefully healthy person and given medication, that's going to be a problem for me. What am you medicating me for, and what is this medication going to do to me?
Let's, there's a lot to unpack here. There's a lot to unpack. First, the trust issue, which I respect. All right, so I do. Now, let's start with, I think you ask, what should I be concerned about? Okay? And I think that you laid it out very well. And that is, what are the diseases and conditions that occur in your family? And those are the things where I think working with your primary care physician, and that physician should take a history and understand what are the things that have been going on in your family and set the stage for helping you develop plans to prevent those things or detect them early. If you've been a smoker, then you may need to talk to your primary care physician about early lung cancer screening. I think Dr. Flanell talked about that. So I say that. Now, I don't think you need to participate in a clinical trial for something that you don't have. Now, I would say that the first phase of clinical trials involve healthy people, and I think you laid out how that gets started. Back when you were in college, they paid people to participate in these trials, and that still happens today, to get healthy people in the first round of the clinical trial. The next round of the clinical trial, though, where it's important that if you have a condition and there are new medicines coming out and you're willing to participate, then that's good, okay? Now, I think I got at least 3 or 4. What did I miss?
Basically, what symptoms are...
Oh, okay, now, yes. All right.
And will biomarkers help me to detect a condition that may not have surfaced as yet?
Okay. So I'm going to divide this up into 2 things. First, biomarkers are related to specific diseases, specific types of cancers, as well as other autoimmune diseases that have already developed and help define the treatment, all right? Now, today, we do have genetic testing where if you have a family history, there have been gene patterns that have been identified that make people more at risk for disease. If you've had a family history, that may be something that you want to do, all right? And I think that is one where you have to have a long discussion with your primary care physician, do your research, get your questions, and then make a plan, all right? So now, second, you ask about symptoms. Now, I want to use Jamie's story just a little bit. And the part of her story that I want to use is that she had a symptom. It didn't go away. Even when it was treated as something insignificant, it didn't go away. And it got worse. But she was persistent, looking with her primary care physician. What I tell people is this: if there's something bothering you, a symptom, something that's not right, it's not getting better, it's getting worse, you need to go see somebody before somebody has to take you to see somebody, if that makes sense.
I'm not one of those people that doesn't check out things. and I do have insurance. And so I'm always saying, well, what about this and what about that? And why did this happen? Why I had an incident where I passed out in the Apple store. And he said, the doctor told me after they took me to the emergency that it was a vasovagal syncope.
Yes.
Okay, now who knows what that is? You got to speak English to me. So the thing is, the relationship with the doctors too.
Yes.
You know, a lot of times they're not really asking the questions. You have to be your own advocate, and a lot of people do not do that.
Right.
You know, a lot of the people, they don't ask the questions. They don't say, oh, it's just a pain in my back.
Right.
Until it becomes
Right.
not just
And,
that.
and some of us go to the doctor, and we don't tell the doctor exactly what's going on because we want them to tell us that there's nothing wrong. Now, that's more common for us as men than women. So, but that gets back to, and I think you said it very well, it's about the relationship with your physician. And that relationship has to be one of trust. And my way of saying to you, if you feel like your primary care physician isn't listening to you, it's not a bad thing to find another one.
That's not as easily said as done either. I'm sorry. But
All right, uh-oh. Some people ask questions, you got to stand up. Go ahead, Dr. Flanell.
I was going to actually help address the one question you had about would the biomarker testing help in detecting earlier, right? Or should you be getting biomarker testing earlier? There are some clinical trials looking into that right now. It's not a standard of care, but if you can look online to see those people who have a risk factor or they have had other types of cancers and should they be getting biomarker tested in advance, you might be able to enroll in one of those clinical trials. And there again, they wouldn't be doing anything that would be a treatment or an intervention or that you'd have side effects from. They would just be looking for early detection and risk factors. They would address all of that too, based on the results that you get back. So if you can look online, you can find some of these. You can go to the CDC sites or the National Institute of Health, and they can see what clinical trials for biomarker testing are available for people. Okay. Thank you.
All right, great. Thank you very much for the opportunity to do this. I hope you learned something about clinical trials. I hope you at least think about the issues of trust and weigh that against the benefits of participation. Now I have the privilege of bringing up the next panel, and the moderator is Ms. Lakimba Desidir. She is the VP and Chief Policy Officer for the Hill Collaborative. Also joining is the Honorable Stan Washington, the Honorable Howard Mosby, and the Honorable Billy McKinney. So thank you very much, and it's been a pleasure talking with you. Thank you. I'm sorry, Billy Mitchell.
Good morning. We're going to let these gentlemen get settled because men take a little longer than women. Good morning. Again, my name is Lakimba Desidir. I am the Chief Policy Officer for Hill Collaborative, and I am excited about this panel that we're about to jump into, or fireside chat. First, I want to say, wow, the information that we've received this morning has been important, has been impactful, and I hope that not only that you got something from it, that you'll be able to share. We heard a personal story from Jamie. Sometimes, a lot of times, things get understood when you can hear a personal story and you're able to connect. And Jamie has been an advocate and a voice in this space, particularly when it comes to people of color, Black folks. And so I'm thankful that she is willing and able to share this story. So thank you, Jamie. Dr. Fernald, breaking down biomarker testing, getting a better understanding of what it is and how important it is to be able to advocate for yourself when you talk to your physician. And then clinical trials, Dr. Sanders. To be very clear, every time you take medication, Tylenol, Zyrtec, over-the-counter. You're doing your own clinical trials. So we got to do better in making sure that we are a part of medicine that is going to be impactful not to just us, but to our families and our communities. So we're going to talk about equitable prevention, early detection, treatment, biomarker testing, research. You know, in order to move forward, you need research, right? And then lung cancer, not just with smoking, but we saw the video, it can be radon, or it can be in the environment that will impact folks. If you have lungs, you can have lung cancer. So that is something that we are going to connect into policy. So I'm going to read the bios of these distinguished gentlemen that I've had the wonderful pleasure of knowing for a very, very, very long time. We'll start with former State Representative Howard Mosby. In the Georgia legislature for over 15 years, sitting on the powerful Health and Human Services Committee, which is the committee that passes legislation and introduces legislation that impact the state of Georgia when it comes to health. In addition, he has over 25 years of healthcare experiences at one of the nation's largest safety net institution housed in Atlanta, Georgia. And he's a financial expert and a licensed certificate public accounting and a chartered global management accountant. Former Representative Stan Watson served in the Georgia legislature. It says decades. I don't want you want me to say decades? I think that was Howard doing that. 10 years, thank you, sir. Serving as a member of the Health and Human Services Committee, worked in healthcare in some capacity for over 20 years. Representative Watson served as a state legislator and also a former chairman of the Georgia Legislative Black Caucus, and served as a former chairman of the DeKalb House delegation. He also served on the DeKalb Library Board for 7 years. And finally, Representative Billy Mitchell. He is serving as a distinguished member of the Georgia General Assembly and was recently appointed by the President of the United States, Joe Biden, to the Presidential Advisory Commission on Advancing Educational Equity, Excellence, and Economy Opportunity for Black Americans. Thank you, Representative Mitchell. He's also served as the president of the National Black Caucus of State Legislators, where he led 740 members of African American state legislators in this nation. I'm going to pause on that because Representative Mitchell was the president of all the black state legislators in the United States. He was the voice, and he led, and we appreciate you for that. Thank you for that clap. He was elected overwhelmingly from the Georgia General Assembly, and he serves on some of the most powerful committees, and is the author of many legislative acts signed into law. He also presently serves as the chair of the Georgia House Democratic Caucus. Thank you all for being here. Representative Mitchell, I'm going to actually start with you since you are a current member. Can you break down the makeup of the General Assembly right now with the House and the Senate, and just kind of give us a better understanding, and break down the numbers, and also break down how many people of color, black folks, represent that?
Turn the mic on. Push it. Yes. First of all, Lakimba, let me just say to you that was perhaps the second best introduction of me in quite some time. The best introduction of me actually occurred a couple weeks ago. I was speaking somewhere, and the person who was to introduce me did not show up, so I had to introduce myself.
Okay, I'll take that then. I'll be second.
You should have heard all the great things I had to say. But thank you so very much for that introduction. And it is, I want to say also, you're just not some passerby. Lakimba used to be the executive director of the NBCSL, National Black Caucus of State Legislators. I will tell you, the organization hasn't been run right since you were the executive director. But the Georgia, it was.
You'll get your check later.
But let me just say that the Georgia legislature consists of 256 members. There's 56 members in, what am I adding right? It is 56 members in the Senate, and there's 180 members in the House of Representatives. 236, the CPA has it down. I will say that Georgia has the largest contingent of African American legislators in the nation. There's 70 some odd in the House and 20 some odd in the Senate. So we have a very large contingent of representatives. You know, based on population, it should be more, but gerrymandering, the party that's the majority, which happens to be another party, they get to draw the lines, and therefore the amount of members that we have reflects who draws the lines.
Is that number different from when you were both state legislators?
Yes, those lines were drawn to make sure that the majority party, the Republicans, could stay in power. When I was in the General Assembly in 97, 98, when I came in to replace Thurber Baker, we had a very different makeup. It was ran by the Democrats. So we could always take the time to look at legislation thoughtfully and make sure that we passed good bills that would affect the state of Georgia. So it was a little bit different for us then in the House and as well as in the Senate. It started changing around 2004, and we saw the changes of what we call the red tide coming in at that time.
So I'm going to jump right into policy bills. Jamie mentioned House Bill 85. Howard, how does that bill move in the state legislature in order to become this bill that gets signed by the governor?
Well, again, thank you very much for having us here at New Life Church. This has been an awesome responsibility. As a former legislator, one of the most powerful tools that we have as a community are former elected officials, because they don't have the same, I would like to say, boundaries on what we can say. So I can talk about some stuff here. So House Bill 85 was a bill that allowed for biomarker testing to be made available to the public. The bill itself states that it applies to governmental payers, so that is Medicaid, Medicare, your VA insurance, anything that the government will pay for from a payment standpoint. This bill actually affects. One of the issues was trying to get this bill through the legislature and not have, so this could be very costly, and insurance companies find that they try to mitigate cost as much as possible in legislation like this. So getting the bill through the House and the Senate without having different things added to it or taken away from was extremely difficult. And this bill actually made it through primarily because it only affected governmental payers. And the state felt like that was a great crack in the door to move this particular issue forward.
You said crack in the door, so is there an opportunity? So House Bill 85 only covers Medicaid, Medicare, VA?
Correct.
Not private insurance?
That is correct.
Is there a possibility, or is there a way or pathway that we could come back to the State House next year, in the next couple of years, with regards to insurance?
Well, yes, there is, and what's important about this conversation here is that you have Representative Billy Mitchell sitting here, who actually sits on the Health and Human Services Committee. He sat on that committee, actually when Stan and I were on that committee as well. We sat on it together, and that was a hot mess, let me just say that. No, we sat on it together, and he he listening to this kind of conversation, seeing how the people have been really engaged in understanding how lung cancer can be affected, or how they can actually benefit from this particular piece of legislation that's passed, him being able to go back to say, hey, Blue Cross Blue Shield or United Healthcare or AmeriGroup, you all need to look at also having the same legislation, and having him here is a great benefit for us, to him to take back to the legislature to say, hey, let's take the next step in getting this out to the entire population.
Representative Mitchell, what are some challenges in implementing specific policies related to lung cancers? I mean, what is it, how is it at the State House?
Well, you know, this is so great that we're having this session here in front of these folks here. And I don't know if Pastor Harris is still here. You know, church, I should, state right off at the beginning, should not just be about a Sunday kind of action. It is these kinds of policy seminars that benefit the folks, almost like Jesus. He just didn't operate on Sunday. And how does policy get affected? As these, they were extraordinary members can tell you, by and large, it comes from folks who are sitting out like in the audience right now. I can recall my first term in the General Assembly. I didn't even know where all the bathrooms were at the time, but I remember a senior citizen had come to me about an issue, and I was in my first committee meeting, and I just mentioned that this senior had a issue with this was education at the time, and 2 or 3 other members said, I'm familiar with that issue. We had that issue. That became law simply because I just brought it up in a committee meeting. And that's how it has to be, even with our health care. If you folk in here have an issue, you have an obligation to go to those who create policy to let them know. You know, there are certain communities in our state and in our nation that if certain issues were going on, they wouldn't stand for it. They'd let the policymakers know that this is an issue of concern to me and you ought to do something about it. Why some of these issues, these maladies affect our community in the way that they do is because we don't seek the help, we don't seek the policy change, we don't seek the kind of help that we need from the healthcare professionals. And if we want to tackle these and other issues, we've got to speak up. We've got to make sure that we let our folks who are doing policy know that this is important to us. And in that way, it'll get done.
Mr. Watson, you have to share that?
I would probably just echo some of the same sentiments the Representative Mitchell indicated. It kind of scares me at times that as a people we don't get involved in the 3 most important things I think that our government has to offer or should provide for us, and that's transportation, health care, and education until it hits the fan. The health care challenges that we're having right now are being covered and being used in policy-making decisions by some of the most powerful people that we call lobbyists in America, and that's the insurance companies. The insurance companies in any state right now probably would have a lot to say about any policy decision before citizens. And so oftentimes you hear a legislator or you hear a person running for office say that they want to talk about health care and want to make sure that the policy implications for health care are brought from the people. So I should say to the audience today is that to make sure that you get people in place in legislative positions that understand the policy needs of our community as it relates to health care. Because the health care advocates are going to have insurance advocates and insurance lobbyists taking people to dinner to make changes in our policy. One that Representative Mosby, my friend, just indicated to you. This particular bill covers only government Medicaid or cover government insurance. Why wouldn't it cover insurance that we use every day? Blue
we
Cross,
pay for.
Aetna, and those challenges are the challenges that we have in dealing with policy. And I would just say, just make sure that when you see these policy changes, our community has to become engaged to make the changes that we need for our policy. Otherwise, we won't see things like biomarker testing.
What do these people need to do? What do
Well, they have to be in
need to do?
tune to legislative priorities. Before the session starts, I think that you need to talk to your legislator to see what are some of the priorities that he or she wants to present. But they also should present your priorities. If your priority is health care or transportation and education, in this instance, since we're here for health care, those sentiments should be made in the community and we should go and work. I asked Representative Mitchell and former Representative Mosby how many African Americans signed this bill, House Bill 85. There is no way when we were in the legislature, when I was in the legislature, that we would let anything that affect our people we would not be a part of. We'd be at least the third signer or the first signer or the author of the bill. And even if we're not the author of the bill and we knew it affected African Americans in our community, we're gonna be the second signer to make sure that this policy change became law in our state because it affected a number of people.
So you need to know who your state legislator is.
Say again?
So you need to know who your state legislator is.
You need to find out who your state legislator is. Not only Mr. Representative Billy Mitchell here, but we need to find out every state legislator as it works to make sure that we can take care of things in our community with policy, because the National Institute of Health, the FDA, the CDCs, our public health system, and our safety net hospitals, they're ran by policy. And the policy is generally the money.
Representative Mitchell?
No, you're hitting the nail right on the head. You know, when I used to do community forums such as this, I used to ask everybody to raise their hand if they knew who their state legislator is, and only about half the audience would raise their hand, and then I'd ask that half who was their legislator, and less than half of them could state who their legislator was. So I don't do that anymore because it became embarrassing. But the reality is that's how the policy gets created. I remember being in the health committee and a legislator proposed a bill that prescriptions, medications for animals, that's what I said, animals, be tax-free, simply because in humans it's tax-free, and he wanted to make sure that the same kind of consideration be given to animals. And believe it or not, they considered that proposal. So we as community members have an obligation to do the same.
And this is a question for all of you. How can policymakers, particularly when the numbers are not balanced in the State House, how can they work together to implement or advocate for legislation, particularly when it comes to lung cancer?
All right, I'll kick it off. So we just got through talking about how House Bill 85 only affects governmental affairs, and it's a crack in the door. The legislative process is really iterative. That is, that you are looking at moving a bill or moving an issue along a time frame. A lot of us look for solutions to happen today. So I have this problem today, I want to make it happen today. The legislative process generally doesn't work that way. It really is, let's find a place where we all can agree, and we'll work on that first. Let's see how this works. And then next year or the year after that, we can come back and expand that even more. But as long as we try to do what I like to call silver bullet answers, that this one shot, if we get this one shot, it'll work. If we don't get the one shot, then I don't have anything to do with it. It's generally what hurts moving policy in underserved communities, because those issues are they're so prevalent, and you want to do something about it. And when you start talking about, well, we want to do pieces about it, the community gets frustrated in that process. But really, follow how people like Representative Mitchell and former Representative Watson and myself, we have to work with people who do not agree with us, people who don't live in communities that look like ours. And sometimes we have to find those areas where we can agree, and then we focus on those. And turn it over to my colleagues.
Yeah. I will say, you know, this is one of the reasons why I love the HEAL Collaborative, because it seeks an opportunity to educate folks, and that's what we need more so than anything else, to get that information out to our community. We suffer from a lack of knowledge sometimes, and it's so very important that we become well-versed in what can happen if we approach our policymakers and if we get the right education that we need. So I want to applaud you all for doing the great work that you do. I will tell you, Madison Avenue, the marketers, as you know, Madison Avenue was in New York, and that's where the bulk of those who market everything to us, their offices are. They do a wonderful job of getting us to buy certain products. Matter of fact, the clothes we're wearing, the cars that we drive, the food that we eat is all influenced to a large degree by what the marketers say is great and good. In our community, they market certain menthol cigarettes and products to us, and we need a like kind of marketing campaign of what needs to happen for our community. You know, as a result of advocacy years ago, you know, you don't see people smoking on television anymore. You don't see advertising and commercials and in magazines anymore because the advocates get so loud that they outlawed that. We need similar advertising campaigns, much like what the HEAL Collaborative is doing, to inform our community so that they can be great advocates for their own health.
Mr. Watson.
Probably I would have to echo the same sentiment. I would also ask our viewing audience to make sure that you have legislators that know how to reach across the aisle and talk to the persons in charge. So right now, Georgia's ran by the Republicans, so we should elect people that have an opportunity to go across the aisle and talk about some of the same challenges, some of the same sentiments that we have as a people. And again, you have to know each other when you're walking across the aisle. So to be an effective legislator and represent my community in the state of Georgia, I have to know the sentiments of what goes on in Savannah down at the port. I have to know what goes on in Columbus at the Army base. I'd have to know what's going on in Rome, what's important to the people in Valdosta as they travel from Valdosta to Florida. So I have to know the state of Georgia in order to have friends. Representative Mitchell and Representative Mosley will tell you, in order to pass a bill in the General Assembly out of 180 people, you have to have 91 friends. All your friends are not going to look like you. So you have to have a person in charge of your particular district, your legislator. He or she should be able to work with the persons in charge to make the changes we need for policy that affects our community each and every day.
I thought you were going to talk about no menthol Sunday. But okay.
All right, gentlemen. I have to pull it together. All right. Okay, so here it is. I heard, know who your legislator is. Go talk to him, he or she. So when it comes to personal stories like Jamie, why is that important to you all? What is the importance, and what role do personal stories play in the State House?
So it's huge. Representative Mitchell and Watson said something that's important. Advocacy organizations make a huge difference in ensuring that views get heard. Personal stories like Jamie Knox's story they're huge to legislators, because what happens is you put a face on an issue. So it's easy to talk about gun violence, but if nobody in your family has ever experienced gun violence, it's something that happens to somebody else. And so when you hear about a lung cancer story from a young woman who was an avid, did kickboxing. Don't mess with her though, so I just want y'all to know that now, because avid kickboxer, and never smoked and ended up with lung cancer, and to come in front of a legislative committee to say, this is why you need to do this, it becomes huge to those legislators to say, this has a face on it now, and it's not just a theoretical situation. It actually happened to somebody.
So community partners or individuals can come to the State House?
Yes. We as a legislator, I usually encourage my community to come visit me at the State House all the time. and also to be accessible in the community, either through our church or through our PTA. That's the only way that we are able to know what some of the best sentiments are for our community. As a legislator, some of my best legislation came from people in the community, and it's something that I didn't think of. It was something that the community brought to me and said this was a challenge for them, or this was something that we can make a change on. Perfect example, I was at home one day, and a guy knocked on the door and said that he had a baby that was not his. I said, well, how does that affect me? He said, you're a legislator because we need to figure out what paternity fraud is all about. So like Jamie's story about lung cancer, this gentleman walked up to me and told me that this baby's not here. We need to make sure that we test DNA testing at the time of birth for birth babies and make sure that men were not just paying for babies that were not theirs. So the personal stories became even more evident for me as a legislator, and it helped me to be a better legislator and pass great legislation.
Were personal stories able to, so folks with personal stories going to the State House, are they able to testify?
Mm-hmm. Absolutely. You know, they make it difficult. I'll be quite candid with you in that it's not going to be held when you get off work. You're going to have to take off work, and you're going to have to navigate to find out when those meetings are. That's why it's important that you have some kind of relationship with your legislator. But let me suggest this to you, and you try this on your own to see if I'm telling you the truth. I think there is nothing more powerful to an elected official than you come up to them, find out who your elected official is. You say, I live at whatever street and address you are my state representative, I can vote for you, and this issue is important to me. There is nothing more important to that person than that. No matter what elected level you are,
and
you go up to them and say, I can vote for you, and this is an issue that's important to me.
And if they're not, then what, vote them out?
I suggest to you that you would immediately get their attention if you say those magic words, I live in your district, I can vote for you, this issue is important to me. But if your issue is not being met, then you have to assert the power that you have and vote in people whose interests share with yours, align with yours.
Clinical trials, we talked about that. Is there legislation or has there been legislation introduced with regards to clinical trials?
Not directly. So what we really need to think about is how policy is made in the United States of America, and then subsequently Georgia. So you have your executive branch, your legislative branch, and your judicial branch. It's early also, work with it, brother. So your judicial branch. And what happens is organizations like the FDA and the National Institutes of Health operate under the President of the United States. So that's the executive branch. One of the issues around the civil rights bill not being moved forward now is because it's an executive branch order. It's not law. And so every 25 years, Congress has to reauthorize this order that has come forward. The Supreme Court ruled, the judicial branch ruled, unless it becomes law, these certain sections in this order we see them as not being constitutional. And so they were struck down. We need to work on what level of government actually is affecting the thing that we're trying to do. So you have your legislative branch that actually statutorily, which means that creates a law around an issue. Biomarker testing, House Bill 85, became statutory. That is, these governmental payers have to pay for it now. It's not an executive branch decision. You saw where a federal judge actually struck down the abortion piece because that abortion issue is not law anywhere. When the Supreme Court struck down Roe versus Wade, now there are no laws around this, and so these federal judges now can make decisions around executive branch decisions around whether or not the FDA's approval of this drug makes sense or not.
Is it important to have clinical trial legislation?
It is important that So this is where it gets to be a little, this is politics now, so this is where it gets a little tricky. It would be great that the FDA could only authorize a drug to go forward statutorily if it meets a certain population criteria on the people who are in the United States. So African Americans make up, let's say, around 12, 13% of the population. That if a drug comes forward to the FDA that didn't have 13% of those people who went through the clinical trial as African Americans, then it would not get passed. It wouldn't get FDA approval. Then that would be great. Your pharmaceutical companies would say, if we can't get this, then this benefit to the population, the R&D dollars that we spent, the billions of dollars that we spent to bring this drug to fruition, people will never have access to it because we didn't get enough African Americans in this study, whereas we can get it out now. So you're weighing those two things happening at one time. Dr. Sanders talked about how even though a lot of these trials have gone forward and African Americans are not in them, they still benefited African Americans to some degree.
Anyone want to add to that?
I think he hit the nail on the head.
He hit it? Okay, if you said so, I believe it. I want to wrap this up with takeaways. What is it that each of you share one takeaway that you think it's important that the audience should know and should do with regards to policy, particularly when it comes to lung cancer?
Who wants to go first?
I would think for the audience, I think that we need to make sure that we know our legislator, and then we need to make sure that we can get in contact with the legislator as it relates to policy. And the policy that I'm talking about are things that are covered for any diagnosis we may have that we may want to get paid for by the insurance company. And so my takeaway is that if you go to the doctor and the doctor does not give you a particular test that's covered, that coverage or that payment comes out of your pocket. So if you talk to your legislator, as we did for biomarker testing, we might be able to get the interest of the other legislators to get this particular bill or policy passed. So my takeaway is to make sure you know your legislator as it relates to especially things like health care to make changes in our community.
Thank you.
And I would add that we as a community really need to get involved in the political process. There is nothing that moves in the United States of America without policy behind it. If you think of anything that's going on in your life that's not affected by policy, please come and tell me what that is, because I just don't know what that is. But I know for a fact that if you don't get involved with the political process, then what they say, if you're not at the table, you're on the menu. And so I would advise each and every one of you to get involved in the political process. And I want to add one other thing too. Advocacy organizations.
I said one.
I know, but advocacy organizations are important. Please lend your voice to issues that will affect your community. In this particular case here, there are a number of lung cancer organizations out there that are actually trying to make a difference for our community.
Thank you, Howard. Appreciate it.
Well, let me just say, and then since I get to wrap up here, is that Representative Mosby said it best. You've got to lend your voice to this process. One of the reasons why I'm so passionate about health care, you show me a well-to-do community, I show you a healthier community. You show me a community that has less crime, I'll show you a healthier community. Show me a community where there's great economic opportunities, I will show you a healthier community. So we have to take control of this issue because it not only benefits you, your family, but it benefits our community. Do I have time to tell a quick story?
Absolutely.
Okay, great. And it reminds me of this story, you know, with the blessings that all of you have here to speak up and speak out on issues. You should make sure you implement that blessing. It reminds me of a story of this older woman who was turning 100 years old, and she raised 3 successful sons, Lakimba. They were all very, very wealthy and had done very well. And they said, you know, for Mother's 100th birthday, why don't we take some of our considerable income and buy her a really nice gift? Well, the first son said, I know what I'm going to buy, Mother. She's lived in this small house all her life. I'm going to buy her this large mansion like Howard Mosby has so she can live out her final days. The other son said, I know what I'm going to buy Mother. Mother's too old. She doesn't drive now. I'm going to buy her a limousine complete with a driver to take Mother around. And the third son says, I know what I'm going to buy Mother. I've gone all over this world, and I saw this exotic bird who can speak 12 languages. It can have conversations. It can read. Oh, the bird is so very expensive, but Mother deserves it. Sure enough, after the mother got the gifts, she wrote all three of her sons. To her first son, she said, why would you buy your mother this big house? I could only stay in one room at a time, but I got to keep the whole house clean. You really don't know your mother. To the second son, she wrote him and said, why would you buy your mother this limousine or this driver? I like the family to take me around. Gas is so expensive and the driver is so rude. You really don't know your mother. But to the third son, she said, yo, you really know your mother. The chicken was delicious. The third
I was
son,
wondering where this was going.
The third son quickly called his mother and said, Mother, you ate that bird? It was so expensive. It could read, it could speak 12 languages. It could have conversations. And the mother said something that I'm going to leave with you. And that is, if the bird could do all that, how come it didn't speak up? With all the talent and all the advocacy ability that you have to speak up, because that is how the process works. That is how policy changes. Thank you so much.
Powerful. Thank you very much.
Good to be here with you.
Do we have any questions from the audience for these gentlemen? Please come to the microphone, please, please. Take your time, but please.
So, this is something that I'm passionate about, along with biomarker testing, and I got 3 legislators on the stage, so I'm going to ask the question because I don't know where to begin. So the lung cancer screening criteria right now is for individuals who are age 55 and older, who have smoked 20 to 30 pack years, and who have quit in the last 15 years. The average age of people getting diagnosed with lung cancer is 71 years old. So there's about 18 to 22% of young people getting diagnosed with late-stage lung cancer because it's not screened and caught. So what do we do for those 18 to 22%, like myself, who are diagnosed at age 32 and younger with late-stage lung cancer who are completely missed by the screening criteria?
So that is an awesome question. And that also actually speaks to something that Representative Mitchell said, and that is being involved in the process. You know, one of the hardest groups to get involved in the legislative process are young folk. Young folk will find every other excuse to not be a part of the legislative process. That's not an answer for why that's not the case, because what Jamie puts forward is exactly true, that a lot of the people that are involved in these studies don't look like us. They don't look like us from soup to nuts, that is from age, community, skin color, socioeconomic background. A lot of the more well-to-do people are involved in these studies. And when these guidelines come out, they're only looking at a small subset of what our society looks like. And so the 50 years old, the 20 pack year requirements come out of the American Cancer Society and other organizations that are making these recommendations. And we're not a part of that. And so we need to be more engaged in these processes in order to get our footprint made available in terms of how these policies are moving forward. Great question, though.
The second part of that also is that the insurance companies who actually are going to pay the bills, they don't want to be mandated to do it all at once. So they'll talk to the legislators, and the other legislators talk to their colleagues, and they'll say, we can do this, but we don't want to increase the risk pool. It's just like your car insurance. We don't want to expand this right away and have to pay for this particular diagnosis if we don't have to pay for it all at once. So we want to do it in segments. So the trick is that how do we get insurance companies out of the way to get policy done so we can make sure that we take care of the entire problem and not just piecemeal a bill. And that the way you have to do that is to beat the insurance companies and their lobbyists to our legislators and make sure that they understand how important it is for us to get it done in our community, even looking at the financial implications that we have if the insurance company was mandated to do it right away.
So just for clarity, lung cancer screening is from 50 to 80 here in Georgia.
50 and 80, well, that's national.
Nationally.
Nationally.
Thank you.
And 20 pack years.
20 pack a year. Okay. Thank you.
Hello, gentlemen. Thank you for being here. My question is, for the advocate organizations, do I need to create my own? Because I would love to use my voice. Also for the marketing campaign for the health. Is that something that I need to do?
Yeah.
So,
I want to add this because I want to join your marketing campaign when it says it's speaking about the health of Black people. And I think our biggest health issue is what we consider soul food.
that is.
I think it's very effective too.
It is, and so your question is very nuanced. I feel like I sound like Dr. Sanders now, but no, you can start your own advocacy organization. What we found though is that synergy works. So we can have a whole bunch of small individual organizations out here moving the needle, trying to move the needle, or we collectively work together to move the needle on. Yeah. Oh yeah. No. We could talk after. Yeah. We could talk. Yeah. She was saying she's not knowledgeable about that, and we could talk after that about different options that you can have in joining with certain groups that actually look like you and talk like you and walk like you.
Yeah. Yeah.
Okay, my question pertains to the government insurance. As a retiree who has had breast cancer, now I have Medicare and I have Blue Cross Blue Shield. Now, Medicare do not pay for a lot of cancer drugs, and they say I made too much money to get Medicaid. So since Medicare is a government program, shouldn't Medicare for seniors and retirees like me, shouldn't they pay for more cancer drugs?
Well, yeah, you're absolutely right, and so in the state of Georgia, so Medicaid, as she talked about, is for that certain piece of the population that is at a certain percent of the federal poverty guideline, and above that, you get out of the Medicaid eligibility framework. Medicare is a federal program. Well, Medicaid is also, but is administered at the state level. I think that your physician, whoever your physician is, can actually advocate not only for you to get covered under your Medicare insurance, but also that Part B piece that you have, they also can advocate ensuring that you get access to that care. The problem with the process, and the reason why we wanted this to be legislation is, you shouldn't have to know stuff. You should be able to go to your doctor and they prescribe to you the thing that you need without you having to have to be this expert almost in these areas. But in this particular case here, your doctor could actually advocate for you, not only with the insurance company, but with whatever payer you have. I'm sorry, insurance you have. They get on me about that. Right. Whatever insurance you have to ensure that you get what you need. But a lot of times doctors don't have the time to do this kind of advocacy because they have so many patients in their book of business that if they had to do it for all of them, they wouldn't be able to make their own money. Right. And so, but it is up to you for you to use your voice to say, listen, I want this test. I want this test because I meet the criteria, or I feel like there is something more wrong with me. You have to, hate to use this word, you have to stand your ground, if you will, in the healthcare space and say, I'm not moving until you do X, Y, Z for me.
And if not you, someone with you when you go.
And yeah, exactly. Yeah. If you don't feel like your voice is that strong, please take people with you to the doctor. Don't go in there by yourself.
Those are all the advocates.
Get somebody to go along with you. This was at our last forum. You don't have to be type A to get good health care, but that's what's happening. People who are strong in this space actually are making this advocacy, but you don't have to be this super person it should happen for you. But if you don't have that, bring it with you.
Yeah, well, look, Kimber, this is why these kind of forms are so very important. I think there's some folk out here, there's some consumers out there now armed with that information, now know that they can go and ask their physician, this is important to me, what can be done about it?
Yeah. I think one of the greatest advocates would be our public again. And if they're going to the physician, like Representative Moses was saying, and you go in to take a test and that test is not covered, that's a legislative matter right away. And why is that test not covered? Yeah. Why are you not paying for it? Because if the doctor say, well, I'll order the test for you, but guess who's gonna pay for it? So that's a legislative matter right away. I mean, something that you can take to your legislator on the state level, or you can take it to your legislator on the federal level, which will be Congress. And while you're talking about Congress, there are certain things that comes down to our safety net hospitals and to the payment issues, and those are what we call diagnostic codes or sometimes. So sometimes we have people out there that will make sure that they don't approve certain diagnostic codes on your explanation of benefits when you get your payments, so to speak, or get your invoice. There are certain diagnostic codes that CMS won't cover. And you wonder why CMS, Center for Medicaid and Medicare, won't cover those particular items for you, is because somebody don't want them to cover them. That means that you don't have to get paid for it, but I mean, the doctor doesn't get paid for them, you have to pay for it. And so then you become another advocate and tell your doctor this should be a test that should be covered. I should have a diagnostic code to submit to Grady or to St. Joe's or Northside where they would pay this bill and my out-of-pocket and deductible will be a lot lower.
Mm-hmm. Thank you all.
Yes, my question is around policy advocacy. I know we
Can you
talked
speak into
about-
the microphone, please?
Oh, my question is around policy advocacy. We spoke about contacting our legislators. Can we empower the audience in how to find out their legislators? As Billy Mitchell stated, you know, you raise your hand, who is he? And then do we have one? And I'm not going to do that to us, but just just a website or something to make it easier to start at ground zero and say, okay, now I know who my legislator is, and now I can reach out to them. Just pragmatically, how can we do that?
Representative Mitchell.
Yes, you know, you could go to, on the state level, www.legis.ga.gov. But if you were to Google, you know, you don't even have to make it that, who are my elected officials, if I live, it would give you not only the state level, but the federal level, the county level, and if you live in a city, it would give you that information as well. And that's, you know, some issues are related to if you live in the city, some of you related in the county, and some are even on the federal level. But if you were to call our office or anything like that, I'd put you in contact with the people you need to be, no matter which level it is. But that's a great question, and where we should start.
Zip code. Put your zip code in.
Yeah, put your zip code in, and it'll.
And who represents me?
Okay, I would just like to say, this is a hard one for me. I was in my store working, and one day somebody just said over the intercom, we are dealing with Ebonics. And Ebonics in the dictionary is Black English. And the question is, how do we get to our own separate English? And the answer is, it's called RAIN. And I say all the time, they would do anything for us if they knew. So they don't care for Grady because Grady takes care of us. And Emory backs up what Grady does. And the RAIN is really a controlling system over the poor. And I don't know what you want to think of it or what you want to do with it, but I am going to say this. In the beginning of your narrative, the woman went to the trouble of checking the housing, not checking her insurance. Because if you went to the insurance companies and say, EPA is not being done correctly and this and the other, or somebody is manipulating the EPA, then that would be a completely different story for the insurance companies. And they would certainly come after them because the ring is controlling the price of the apartment without the quality of the apartment.
Can you repeat what you want us to message to everyone a little
Well,
louder?
because the beginning of the health situation was she found out that radon was in her
Okay.
was in her apartment.
Okay.
And that it caused this illness. And she went through the whole neighborhood to make sure
Gotcha.
that it was not affecting everybody in her apartment. And it could have been just her because they didn't like her because she was an outspoken woman. And an outspoken woman who changed process and procedure. They don't like you. And it happens.
It does.
You are good people. There's a person in front of me who is shaking her head and saying, "We know you love us." So I got upset, so I'm here. Because you just said, don't stand alone.
Thank you. Radon legislation.
Well, one of the things I know that here in DeKalb County, if you would call your local fire department, they would give you free radon kits to put in your house here in DeKalb County. I'm not sure about Fulton or Cobb County, but in DeKalb County, if you would like a radon kit in your house, they give them away free from our fire department. Those are free to the public. And I think we talked in our last session about radon, and I was surprised that we didn't mention that some of the municipalities would have those kits free for everybody who wants them to put them in their homes.
To your point, environmental factors are also policy related, and where communities are built. So when we moved to DeKalb County, the landfills out there were in the rural area. They were rural. Now today you have housing communities built around them, and the county commission approved the zoning of those properties those houses being built around a landfill. So all of the environmental factors that come out of that comes from, at the end of the day, from policy being made that allow for this to go forward. The same thing that happens with radon. If you start looking at where homes are being built and where you see this as a problem, generally it's going to be underserved communities. Communities like people in this room. Right. And that's because, as Representative Mitchell says, we're not at the table. To her point, she was really speaking about how, from what I gathered from what she said, was that she wants to lend her voice to trying to move the needle, and she doesn't have that kind of a strong voice. This woman stood up in her community, and she went to all the houses to ensure that this radon issue was being captured. But we have to figure out ways that we can ensure that our community understands and knows about these things. One of the reasons why New Life and HEAL Collaborative is out here today is so we bring this information to you. You don't have to go out and you have to pay for it. It is right here in your community, and it's about bringing this to you so that you can know what to do to advocate for yourselves.
Well, thank you, gentlemen, Representative Mitchell, Representative Watson, and Representative Mosby. We appreciate you. Thank you for your leadership and your dedication and your investment in the state of Georgia.
Thank you.
I'm going to pass this over to Stan Watson to wrap us up.
Thank you so much. Let's give LaKimba a hand, if you would, please. Thank you so very much for being here today. I'm going to put on my other hat. Let's give New Life and HEAL Collaborative a hand also for presenting this today. Now, if you would, there were some surveys that we asked that you would turn those in, and everyone that completes the survey and was here today, you should receive a certificate as well. So before you leave today, please give us those surveys so we can make sure the HEAL Collaborative and our sponsor, Amgen, understands what we've done here today was beneficial for our community. Would you do that for us today, please? And make you pass those out. Yes, ma'am? It's inside the folder? Okay, it's inside their folders. So would you complete those for us and get those today? We have some people from Hill will pick those up as well, and everyone that's here today will get a certificate. Again, would you give Pastor Marlon Harris a hand as well today? Lunch will be served outside after this, and we're going to send everybody home with travel, grace, and mercy. I'd like to thank Representative Billy Mitchell for being with us this day and also being part of our panel. Let's go home in prayer. Well, let us pray. Gracious God, our Father, we come to thank you for this day. We thank you, God, for Pastor Marlon Harris and New Life Church. We thank you, God, for the Hill Collaborative and those that have come that didn't think it was robbery to be here today to get this information. Ask God that you help us to be not just hearers of the word, but be doers of the word also, and that we take this word to our community, to our other churches, and to our synagogues, and to our PTAs, and everywhere that we can share this word, because we should be workers in the vineyard because the laborers are few. Now, God,